Hi everyone, welcome to our presentation about neurodegenerative diseases. Along with this PowerPoint, you'll find a transcript of the presentation and a worksheet. As you go through these slides, we encourage you to fill out the worksheet. There's a summary table to help you keep track of the key treatments, and there are also some questions for you to fill out at the end of the presentation to help you reflect. The references attached to both the worksheet and the transcript could be helpful when you come to write the final exam. At a couple of points in the presentation, we'll ask you to pause to fill out the worksheet or complete an activity. Brae and Yashi will give you more instructions about those as they come up. We hope you enjoy learning about neurodegenerative diseases and come out of the presentation today feeling hopeful and excited about the future of treatments. Let's get started. Neurodegenerative diseases involve the breakdown of nerve cells with two common symptoms. Ataxias are movement problems that often result from damage to motor neurons. These can include stiffness, uncontrollable movements, called dyskinesia, and tremors. The other symptom is cognitive impairment. While dementia is most often associated with Alzheimer's disease, it's also a common symptom of other neurodegenerative diseases. We'll be addressing the most common diseases, Alzheimer's and Parkinson's. Others include Huntington's, multiple sclerosis, prion diseases, and motor neuron diseases, which include ALS, among others. Before we can dive into current and emerging treatments, it's important to understand a little about the mechanisms underlying neurodegeneration. As you can see from the image on the right, these diseases create a perfect storm of cellular dysfunction. First, autophagy, which would normally contribute to cell maintenance and homeostasis, is impaired. This is especially problematic as neurodegenerative diseases usually involve more misfolded proteins and aggregates, dysfunctional mitochondria, and increased oxidative stress. The damaged compounds are left unchecked in the cell, encouraging pro-apoptotic pathways. When dead cells and misfolded proteins are then released into the extracellular matrix, glia cells are activated to cause neuroinflammation by releasing cytokines and free radicals, which increase oxidative stress in the neuron. Oxidative stress is exacerbated by increased cytokine levels and dysfunctional mitochondria, and can't be remedied because the antioxidant mechanisms are also affected. As we look into treatments, it's important to remember that the key cycle is a positive feedback loop between oxidative stress, misfolded proteins, and mitochondrial dysfunction. Neuronal activity also changes. Pro-apoptotic pathways are influenced by increased calcium in the neuron because of changes in synaptic receptors and neurotransmitter release. When all these mechanisms are damaged and the cells die, ideally they would be replaced. In nerve cells, that would be neurogenesis, which is essential to healthy cognitive function. Sadly, in neurodegenerative diseases, it occurs at a much slower rate, if at all. Huntington's disease causes death of neurons with three common symptoms: dyskinesia, abnormal posture, and cognitive impairment, which includes behavioral and emotional changes, impaired judgment, even psychosis. Gradually, the putamen and caudate nuclei are damaged, and eventually it progresses to cortical atrophy. Current treatments only target the symptoms, so patients die 10 to 30 years after the onset of symptoms. Drugs can be used to treat the dyskinesia, and antipsychotics can help with hallucinations or outbursts associated with psychosis. You'll remember from our first test that Huntington's has a clear underlying genetic cause, which means it can be used as a kind of model disorder to develop treatments that might work for other neurodegenerative disorders. Huntington's is an autosomal dominant disorder, so even heterozygotes with just one copy of the mutant gene will express the mutant protein. The mutations include an expanded glutamate trinucleotide and a few single nucleotide polymorphisms on the Huntington gene. The wild-type Huntington gene is important in transcription, synaptic transmission, and mitochondrial function, among other cellular functions, so the ideal treatment would stop the expression of the mutant gene and allow the expression of the normal gene. One possibility is gene silencing. There are two possible targets for selecting the gene to silence. The first is the expanded CAG trinucleotide. This could only be used in extreme expansions because the length of a shorter mutant repeat often overlaps with a longer normal repeat. Therefore, single nucleotide polymorphisms are preferred. Most therapies target RNA that's encoded in the Huntington gene to block translation by degrading it. These therapies either use antisense oligonucleotides, or ASOs, which are on the left side of the figure, or they enter the microRNA pathway, which is shown on the right side. We can start by looking at the microRNA pathway. Remember that the pathway affects the translation and stability of mRNA. For the therapy, viral vectors with synthetic RNA are transcribed in the cell to small interfering RNA. This synthetic RNA forms an RNA-induced silencing complex, or RISC. It can enter the microRNA pathway at various points, which all allow for RISC formation, leading to both mRNA degradation and repression of translation. Antisense oligonucleotides also degrade mRNA, but they don't require a viral vector, which might be a better option. They bind to and degrade the mRNA even before it's spliced, which is helpful because many of the SNPs are found in introns that are spliced before they reach mature mRNA. They can also target the mature mRNA. The figure on the right side represents researchers' hopes for the future of gene silencing. They plan to develop a choice of ASO drugs that could be prescribed based on the patient's combination of single nucleotide polymorphisms. Multiple sclerosis is a neurodegenerative disease that appears as muscle weakness, sometimes leading to paralysis, phantom sensations, pain, and in some cases, mild cognitive impairment. It is an autoimmune disease that targets the myelin sheath of motor neurons. As a result, signals to effectors are not transmitted efficiently. The onset age is between 20 and 40, and patients can often go into periods of remission. Like many other autoimmune diseases, it's more common in women, which makes the treatment we'll be looking at particularly interesting. Researchers noticed that pregnant MS patients were often in remission. This has been accredited to the increased levels of estradiol and other sex hormones. Sex hormones help to decrease immune function, which is important during pregnancy so that the body doesn't target fetal tissues that have both maternal and paternal antigens. By suppressing the immune system, the disease lessens its attack on the myelin sheath. It's also suggested that estradiol mediates remyelination. During pregnancy, more oligodendrocytes are produced. They are the cells responsible for myelination. So during pregnancy, more axons in the maternal central nervous system are myelinated. Estrogen treatments are still in clinical trials, but there has been at least one encouraging phase 1 trial. Lesions, those are areas of damage to the CNS where the myelin sheath has been attacked, decreased throughout the course of treatment. However, when the treatment was stopped, the lesions reappeared at pre-treatment levels. Other sex hormones, including progesterone and testosterone, have also been shown to play roles in neuroinflammation and neuroprotection. Since levels of these hormones are lower in men and women with MS, they provide a possible insight into an underlying cause of MS and hold promise for a treatment in the future. Early-stage trials have shown neuron and gray matter repair when progesterone and testosterone are administered. Before these treatments can be widely used, though, problems with administration and side effects will have to be addressed. ALS is a motor neuron disease that has received a lot of attention in recent years. Its symptoms include muscle weakness and wasting, often starting with the arms and legs. Eventually, it targets gastrointestinal and respiratory muscles, so patients can't swallow or breathe on their own. These symptoms are caused by the breakdown of upper and lower motor neurons that control voluntary movement. The exact causes and mechanisms aren't confirmed, but they include changes in energy metabolism by mitochondria, changes to cytoskeletal and axonal transport, inflammation, dangerous protein aggregates, higher oxidative stress, and hyperexcitability because of excessive neurotransmitter release. The onset age varies, but it's most often between 50 and 75. Because current treatments only target the symptoms, most people die 3 to 5 years after onset from respiratory failure, although about 10% will live for 10 or more years. We're going to look at 2 drugs that are currently in use to treat ALS. The first is riluzole. It simply reduces the amount of glutamate that's released and received by the neurons. Studies have shown that it did extend patient survival by 2 to 3 months, but eventually, as rat trials show, there's just too much glutamate being released to overcome. Until a couple of years ago, riluzole was the only available medication, but edaravone has now been approved. It's an antioxidant, a free radical scavenger, although its mechanism and interaction with those free radicals isn't well understood. Studies used 3-nitrotyrosine levels in the cerebrospinal fluid as an indicator of oxidative stress. Treatment with edaravone did decrease the amount of 3-NT and slowed the progression of the disease. Unfortunately, because this is a new drug, there haven't yet been enough long-term trials to determine if it actually prolongs life.
Alzheimer's is currently an incurable disease that causes progressive degeneration and death of nerve cells. Dementia is a major symptom of Alzheimer's, which involves memory impairment and difficulty in day-to-day functioning. Vascular dementia is a common cause of Alzheimer's, which blocks or reduces blood flow to the brain. Behavioral and psychological symptoms of dementia include elation, anxiety, hallucinations, irritability, abnormal motor behavior, apathy, depression, and changes in sleep and appetite. Antipsychotics can be used to help with these symptoms, but they are risky as they can be fatal in some individuals. Currently, treatments for Alzheimer's treat these symptoms rather than slowing or reversing the progression of the disease. Familial Alzheimer's relates to mutations in amyloid precursor protein, or APP, presenilin 1 and 2, and in just a few minutes I'll explain the role of APP in Alzheimer's.
The following exercise is similar to one found on the mini-Cobb test, which is a diagnostic tool used for those who may have Alzheimer's. So please pause and take a moment to look over and memorize the following words. When you're ready, you can resume the presentation.
Now, we'll be talking about some clinical trials targeted at amyloid for treatments of Alzheimer's, as well as some preventative therapies and interventions. But before we begin, I'd like to give a little bit of background on what amyloid beta is. So, amyloid beta is a protein that comes from the breakdown of a larger protein called amyloid precursor protein, or APP. It accumulates to form plaques associated with Alzheimer's disease in a process called cerebral amyloidosis. We will discuss how this relates to Alzheimer's in the following slides. According to the amyloid cascade hypothesis, asymptomatic cerebral amyloidosis begins years before the onset of any symptoms of Alzheimer's disease. Cerebral amyloidosis is a buildup of protein deposits in the small blood vessels of the brain, leading to stroke, brain hemorrhage, and dementia. Amyloid beta accumulates in the brain when it leaves its reservoir in the cerebrospinal fluid, or CSF, and forms toxic aggregates that are deposited on neuronal surfaces and in synaptic terminals. For the past 30 or so years, treatment research has been focused on reducing amyloid beta production using beta and gamma secretase inhibitors, active and passive immunotherapies to increase amyloid beta clearance, and preventing the formation of the toxic aggregates that I just mentioned. Here you can see a table of all the amyloid-focused drugs and therapies tested in the clinical trials that were included in this review. I'll briefly touch on the therapies that were not successful and mention why, as well as discuss what we can learn from these failed clinical trials and implement to future studies. If you look on the second to last column, you'll see that only one of these trials had positive results. That was BAN 2401, and I'll discuss this in more detail later on. So, like I said, most of these trials were unsuccessful. In fact, all of these trials specifically focused on reducing amyloid beta formation failed. The theory behind these trials was that reducing amyloid beta generation involved controlling the function of beta and gamma secretase in converting amyloid precursor protein, or APP, to amyloid beta. BACE1 inhibitors showed promise in reducing amyloid beta production in animal models, but failed clinical trials due to a lack of efficacy or long-term adverse effects. A recent study was effective in reversing amyloid beta buildup and improving cognitive function in mouse models with familial Alzheimer's. This suggests that sequential and gradual inhibition of BACE1 could be effective in treating Alzheimer's, but BACE1 is required for optimal cognitive functioning, so more research is required to find an option with minimal adverse effects. APP and Notch are substrates of gamma secretase that are known to have implications in Alzheimer's. Non-selective gamma secretase inhibitors have shown promise in reducing brain amyloid beta and Notch signaling, but seem to cause gastrointestinal complications and lead to a compromised immune system as well as declines in cognitive functioning and sometimes even skin cancer. A few selective gamma secretase inhibitors were also tested in reducing amyloid beta formation. Gleevec did reduce amyloid beta production but failed to impair Notch cleavage in animal models. Avegistat selectively inhibited APP processing over Notch cleavage, and the clinical trial was discontinued due to adverse effects. Non-steroidal anti-inflammatory drugs, or NSAIDs, were the first gamma secretase modulators that showed an ability to convert the form of amyloid beta that forms toxic aggregates into a more soluble form. However, the NSAID R-flurbiprofen was not efficacious in clinical trials in treating mild Alzheimer's. Despite the fact that none of these drugs were effective or safe in human models, we must continue looking for drugs to reduce amyloid beta production. We know that the buildup of toxic aggregates of amyloid beta in the small blood vessels of the brain blocks blood flow and contributes to Alzheimer's. We just need to find a drug that can prevent this in human models and has minimal adverse effects. The AN 1792 vaccine was the first active anti-amyloid beta immunization to undergo clinical trials, but failed as it caused severe meningoencephalitis in some individuals. Clinical trials for Afitope 2 were terminated, and no reason was given in this review. As of the most recent update in April, CAD 106 trials were terminated, and I couldn't find a reason, but it was likely due to adverse effects or ineffectiveness. Passive anti-amyloid beta immunotherapies may be a more effective way of preventing or slowing the progression of Alzheimer's, but up to date, most trials have failed. Bapineuzumab is an antibody that targets the N-terminus of soluble amyloid beta, but it was found to be ineffective at treating mild to moderate Alzheimer's in clinical trials. Solanezumab targets the amyloid beta 16 to 24 epitope, but only recognizes soluble, not fibrillary amyloid beta. This is important because fibrillary amyloid beta is the one associated with plaque formation. Solanezumab failed the clinical trial on mild Alzheimer's. BAN 2401 is a passive anti-amyloid beta immunotherapy that targets soluble amyloid beta protofibrils and has had positive results in a phase 2 clinical trial. The trial included 856 individuals with mild cognitive impairment or mild Alzheimer's with confirmed amyloid beta pathology, meaning amyloid beta plaques were the root cause of the cognitive impairment. The highest dosage treatment group, which was given 10 milligrams per kilogram of body weight biweekly, showed statistically significant efficacy in slowing the progression after 18 months. The efficacy was measured by the Alzheimer's Disease Composite Score, the Alzheimer's Disease Assessment Scale Cognitive Subscale Score, and amyloid PET scans showing reduced brain amyloid accumulation. When interpreting these results, though, we must be cautious. The individuals that were most genetically susceptible to Alzheimer's, those who have 2 APOE4 alleles, were not included in the trial. Having one E4 allele increases your risk for developing AD by 2 to 3-fold, and 2 E4 alleles increases your risk for Alzheimer's by 12-fold. This is concerning because we don't know if this type of treatment will work for these individuals. We need to continue researching immunotherapies, especially passive immunotherapies, to find more treatments that are effective and safe in human models. More trials on BAN 2401 should also be conducted, this time including individuals with E4 alleles to test its effectiveness on this part of the population. Next, I'll be discussing some primary prevention interventions for Alzheimer's. So on this slide, you'll see an extension of the table from slide 15 that includes different therapies and interventions for Alzheimer's prevention. In the following slides, I'll discuss the effect of primary prevention interventions on Alzheimer's. So there are two types of prevention interventions in Alzheimer's treatment. Primary prevention interventions are those that aim to decrease modifiable risk factors for Alzheimer's through strategies like lifestyle changes, comorbidity treatments, supplemental and multi-domain interventions. Secondary prevention interventions aim to initiate mechanism-based interventions to treat underlying pathophysiology so that Alzheimer's symptoms never develop. I'm going to be focusing on primary prevention interventions. So hypertension, or high blood pressure, and hyperlipidemia, or high blood lipid concentration, are considered to be major cardiovascular risk factors for the development of Alzheimer's. From the Vascular Dementia Project, it was determined that for every 1,000 individuals treated for hypertension, 19 cases of dementia could be prevented. Hyperlipidemia as a risk factor for Alzheimer's, however, remains a controversial topic, as there has been no evidence that statins used to reduce blood lipid concentration have any influence on the prevention of Alzheimer's. Diabetes is considered to be another potential predictor of Alzheimer's. One study examined the effect of intensive control of hemoglobin A1C on the prevention of Alzheimer's. The results showed that, compared to the control group, the experimental group only had a 6% increase in total brain volume, and there were no differences in cognitive scores between the two groups. So, thus far, treating diabetes by controlling hemoglobin A1C hasn't helped prevent Alzheimer's. Pilot studies on insulin treatment showed beneficial outcomes in preventing Alzheimer's. A clinical trial called SNF, or Study of Nasal Insulin to Prevent Forgetfulness, is currently ongoing and measuring the effects of intranasal insulin on cognitive decline, brain volume loss, and changes in CSF biomarkers. 2 clinical trials on insulin sensitizing agents were included in this review. The metformin study was completed, and from the clinical trial site, it seemed like there weren't many adverse effects, but I couldn't find anything on how effective it was. As for pioglitazone, I couldn't find any updates. If anyone would like to keep tabs on these trials, I've included links to their clinical trial pages in the references. The Mediterranean diet, which is rich in fruits and vegetables, olive oil, and fish, may reduce the risk of developing Alzheimer's by up to 50% and has persisting effects even if the diet isn't followed rigorously. More trials are currently underway to prove or disprove its effectiveness. Current evidence on physical activity alone is not enough to make recommendations on a specific exercise regimen that will decrease risk for Alzheimer's. However, exercise in conjunction with social and cognitive stimulation, as well as diet modifications, may be more beneficial for prevention. Vitamin E by itself showed no benefit in reducing risk of Alzheimer's, but when used in conjunction with memantine, there was a 19% reduction in functional decline per year over the 4-year period. Although finding a cure for Alzheimer's that has already progressed is crucial, preventative measures are just as, if not more important. Maintaining a healthy mind and body have so many benefits beyond just preventing Alzheimer's disease, for example, reduced risk of cardiovascular disease. Increased availability of genetic testing to individuals at a young age would allow them to weigh the risks and develop a preventative plan with their healthcare provider. In order to do that, though, we need to continue research on the effectiveness of these preventative measures.
Another potential treatment for Alzheimer's is the use of cholinesterase inhibitors, and I will be focusing specifically on the inhibitor rivastigmine, and it's important to know that this is more of a current existing treatment than a novel treatment. The figure provides an overview of the cholinergic hypothesis, which was initially presented over 20 years ago and suggests that the cholinergic system is severely damaged, where increased activity of the enzyme acetylcholinesterase causes greater degradation of acetylcholine, which results in the loss of neuronal transmission. This is a major contributor to the cognitive decline observed in AD patients. So, a therapeutic strategy would be to restore the cholinergic activity in the central nervous system with the use of a cholinesterase inhibitor such as rivastigmine. Rivastigmine, an orally administered drug, was approved to treat mild to moderate AD in 2000. This drug inhibits the activity of acetylcholinesterase and maintains high levels of acetylcholine at the synaptic cleft and improves neuronal transmission. Rivastigmine prefers to act at the hippocampus and cortex of the brain, where cholinergic deficiency is more prominent. Regarding the dosage procedure, the drug should be administered carefully and the patient should be well observed to ensure they experience minimal side effects. The recommendation is that treatment should start at 3 mg a day for 4 weeks, which should then be increased gradually to 6 mg a day. Doses of 9 and 12 mg a day will be recommended after 4 weeks of well-tolerated treatment at previous dosages. However, not all patients need to be given a high dosage. If treatment with rivastigmine is postponed for any reason, dosing should be restarted with the lowest dose followed by repeating the upward dose titration procedure. Moving on to the pharmacological features of rivastigmine, it has a low protein binding capacity, which is an important feature because it's a drug that's commonly used for elderly people who could also be taking other medications. In this case, there will be fewer interactions of rivastigmine with other drugs due to its low protein binding capacity. It is a carbamate that binds to both the esteracic and ionic sites of acetylcholinesterase, which cleaves the rivastigmine molecule, releasing a pharmacologically inert phenolic product that is excreted via the renal system 24 hours approximately after administration. Studies were conducted on assessing the efficacy of rivastigmine in patients with mild to moderate AD. It was found that the efficacy of rivastigmine is dose-dependent. 2 multicenter trials were conducted on patients aged 45 to 90 years, assigned to a control group, and treatment groups of doses 1 to 4 milligrams a day or 6 to 12 milligrams a day. They used the Alzheimer's Disease Assessment Scale Cognitive Section, Clinician Interview-Based Impression of Change Scale, and Mini-Mental State Examination to assess the efficacy of rivastigmine in treating AD. Patients given 6 to 12 milligrams of rivastigmine a day showed significant improvements or no decline in cognitive function, global function, and activities of daily living compared with the placebo group, as assessments were made at week 12, 18, and 26. Research was also extended to study the efficacy of rivastigmine in patients with moderate to severe AD at long-term care facilities. Patients were given a dosage of 3 to 12 milligrams of rivastigmine a day, conducted over 26 weeks. Results showed that cognitive function, performance of daily activities, and global function were better in patients given rivastigmine than the placebo, assessed by instruments such as the Neuropsychiatric Inventory, Nursing Home, and the Mini-Mental State Examination. Although clinical trials have confirmed that rivastigmine is safe and well tolerated by patients, it has the potential to increase acetylcholine levels in the body, which imposes the risk of side effects caused by increased acetylcholine. Most severe adverse effects of rivastigmine occur when patients who are underweight are administered the drug, when patients are given higher doses, and during the upward dose titration procedure. But these side effects often resolve after 1 to 3 weeks of treatment, and the most commonly observed side effects are stomach pain, weight loss, diarrhea, loss of appetite, vomiting, chest pain, breathing difficulty, and slow or irregular heartbeat. Next, I'll be focusing on passive immunotherapy targeting Tau. A major hallmark of AD is neurofibrillary tangles of Tau protein, which was discovered in 1998 by Brae and others, and they are found primarily in neurons. Abnormalities and chemical changes make the connected proteins come apart and stick to other molecules, which give rise to the messy tangles in neurons. These tangles then interrupt synaptic communication between neurons. Abnormal Tau also does not bind to and stabilize microtubules, which play an important role in transporting important substances between neurons and other cells. Tau in the brain accumulates throughout the progression of AD with its origins at the entorhinal cortex and hippocampus. The stage of AD and how severe the condition is depends on the total amount of abnormal Tau in the brain. However, accumulation of Tau neurofibrillary tangles cannot yet be measured with a blood test. Passive immunotherapy against Tau clears up the large abnormal protein aggregates and tangles, which improves cognitive function. Tau immunotherapy is a relatively new area of research with 8 ongoing clinical trials at present, with 6 focusing on passive immunotherapy, so this limits the data obtained to animal models. One of the greatest challenges in finding a therapeutic is due to the low accuracy rates at targeting abnormal Tau. On the other hand, a major benefit of passive immunotherapy is that highly specific antibodies can be manufactured to target strains of the desired abnormal protein, which is currently the main focus on developing a therapeutic. The first step in the mechanism of antibody action in passive immunotherapy is the uptake of Tau aggregates by the phagosome, which indirectly activates the uptake of antibodies via endocytosis. The phagosomes fuse with the antibody-containing endosomes, which then fuses with lysosomes, causing degradation of Tau aggregates. Alternatively, antibodies bind to Tau aggregates following diffusion through the neuronal membrane, and this complex then degrades through mechanisms of action of the endosomal-lysosomal pathway. Both intracellular and extracellular pathways are involved in passive immunotherapy against Tau, and the importance of each depends on factors such as the tauopathy being targeted, stage of the disease, and features of the antibody such as charge, epitope, isotype, affinity, and the size of the antibody. With regards to toxicity concerns, none of the passive antibodies used in mouse models have reported any side effects. There haven't been any serious adverse effects reported from the clinical trials, and many have advanced to the phase 2 stage. It is important to note that one Tau antibody in human phase 1 stage was discontinued, but this wasn't due to safety or efficacy concerns. The prime reason for the study to be discontinued was due to the short half-life of the Tau antibody. However, it was found that there's a chance for the Tau antibodies to interact with Tau in the endosomal lysosomal complex, which could lead to the degradation of lysosomes. It is also possible for antibodies to leak into the cytoplasm from the endosomes or lysosomes, which could potentially interfere with the regular functions of Tau. Finally, it is not yet clear if normal Tau has an important physiological function, but if it does, clearing up extracellular Tau can be harmful. We have a mini Alzheimer's activity for you, so please pause and click on the link below to play the picture memory game by Bright Focus Foundation.
Now we will discuss the novel treatments for Parkinson's disease. For some context, Parkinson's disease is caused by the impairment or death of dopaminergic neurons in regions of the brain that play a role in motor control and movement. Common symptoms include tremors, slow movements, and rigidity. As the disease progresses, symptoms worsen and non-motor symptoms can develop, including sleep and mood disorders, hallucinations and delusions, and cognitive changes. Unfortunately, the current treatments for Parkinson's disease are not curative. Their purpose is to only manage the symptoms of the disease. There are multiple therapies being used to treat Parkinson's, including drug and surgical treatments. The method of treatment varies from patient to patient and depends on the progression of the disease. Generally, the effects of the treatments diminish over prolonged use, and dosages will need to be increased over time. The longer a patient is being treated, the risk of side effects and complications increase. The most common and effective drug used to treat Parkinson's is levodopa. It is considered the gold standard amongst Parkinson's treatments. Levodopa is administered orally or through infusion and is able to cross the blood-brain barrier, which is something dopamine is unable to do. Once it has crossed that barrier, it is converted to dopamine in hopes of replacing the dopamine lost as a result of the disease. It is meant to manage the common symptoms of the disease, including tremors, stiffness, and slow movements. There are mild to severe side effects associated with this treatment, and long-term use leads to increased risk of complications, including wearing off effects, on and off fluctuations, and freezing. Deep brain stimulation is a very effective surgical approach to treating Parkinson's disease. It reduces dyskinesia and the need for dopaminergic treatments, such as levodopa. It is proven to have long-term effects and vastly improves the quality of life for patients. It is not an option for all Parkinson's patients, and there is a lengthy selection process for this treatment. Typically, people aren't considered unless they have suffered from the disease for about 13 years or more. The procedure consists of implanting an electrode in a certain area of the brain, an extension that runs through the head and neck to the neurostimulator located near the collarbone. The neurostimulator sends impulses through the extension to the electrode in order to disrupt the abnormal brain activity that is causing Parkinson's symptoms. The area of the brain typically targeted is the subthalamic nucleus and internal globus pallidus. The first novel treatment for Parkinson's that we'll touch on is stem cell therapy. Stem cells is a general term used to describe undifferentiated cells that are able to differentiate into any cell type of the body and are also capable of unlimited self-renewal, meaning they can continuously divide and reproduce. There are two major classes of stem cells, pluripotent and multipotent. Pluripotent stem cells are those that are researched and used most when it comes to potential Parkinson's treatments because they are capable of greater diversification. Current treatments for Parkinson's can take a big toll on a patient because of their varying side effects. Many side effects associated with these treatments are considered off-target side effects, meaning they are the result of dopamine being administered and taking action in areas of the brain that is not needed, nor is it usually found. These side effects include hallucinations and cognitive impairments. Therefore, there needs to be a treatment for this disease that has a more targeted administration of dopamine to the brain, which is what stem cell therapy would offer. After decades of research, it was concluded that embryonic stem cells and induced pluripotent stem cells seem to be the most promising in potential Parkinson's treatments. Embryonic stem cells are retrieved from the inner cell mass of the blastocyst, which is a structure found in the early development stages of an embryo. Those working with this type of cell attempt to differentiate them into dopaminergic neurons. After over a decade of trial and error, researchers established a protocol to efficiently differentiate and generate embryonic stem cells into cells that resemble authentic dopaminergic neurons. This protocol involves enriching the stem cells with lentiviral vectors to trigger the expression of LMX1A, which is the gene that is involved in the development of dopaminergic neurons. This method leads to the overall success of producing dopamine synthesizing cells. So far, there has been success in transplanting these cells into the brain of rodents and seeing improvement in the motor symptoms of Parkinson's. The other type of cell that are considered a potential future treatment are induced pluripotent stem cells. In order to obtain these cells, somatic cells are regenerated into stem cells through the use of several transcription factors that bring about pluripotency. Once this is achieved, they are differentiated into dopaminergic neurons, using a similar method to that of embryonic stem cell differentiation. An advantage to using induced pluripotent stem cells is that since we are using cells that originate from the patient to create those that will be grafted, there is no need for immunosuppression, which would be required if using embryonic stem cells. The induced pluripotent stem cell grafts have been trialed in primates recently, and there has been overall positive results. This figure depicts a simplified explanation of the process used in stem cell treatment. The stem cell of preference, either embryonic or induced pluripotent, is first retrieved from their respective sources, then transferred to a plate where the cells are left to expand and self-renew. The cells are then enriched and prepared with the necessary genes and markers to differentiate them into dopaminergic neurons. Once differentiation is complete in vitro, cells are selected and transplanted into the patient's brain, where the cells can fully mature and begin to synthesize dopamine and replace what was lost as a result of the disease. Like any other treatment, there are concerns associated with this method. First, there are the obvious risks that go along with the neurosurgical procedures that are involved with this type of treatment. Also, as mentioned before, grafts using embryonic stem cells would require immunosuppression, which leads to increased risk of complications and post-procedure infections. If a case is hereditary, the autologous grafts from the induced pluripotent stem cells could carry the genetic factors that brought about Parkinson's in the first place. Another thing to consider is that this type of treatment would work on patients with only motor symptoms, and the treatment would not be curative, however, it would greatly reduce symptoms and off-target side effects would be avoided. Finally, there are some ethical and economic concerns with this treatment. Ethically speaking, some have an issue with where the stem cells are retrieved from, and in terms of economics, these procedures would be very expensive to develop and could also be expensive for patients. Nonetheless, researchers and healthcare professionals believe that these concerns are surmountable and the benefits of this type of treatment would outweigh any disadvantages. With the success of the trials in rodents and primates, clinical trials are preparing to begin. If this treatment were to come to fruition and be available to patients, it would most likely be combined with others to treat the disease. Stem cell treatment could work to restore the dopaminergic neurons that have been lost because of Parkinson's, while other therapies could work to diminish the continued progression of the disease.
Another treatment that has been growing in popularity recently involves glial cell line-derived neurotrophic factor, or GDNF. GDNF has been shown to have neuroprotective and neurorestorative effects in non-human trials, so researchers think there is potential for GDNF to slow, stop, and even possibly reverse Parkinson's disease. The experiment they performed did not result in any statistically significant differences between the GDNF treatment group and the placebo group after 40 weeks or 80 weeks, but both groups experienced a reduction in symptoms of about 25%. After the 80th week, the GDNF treatment group had significantly improved scores in terms of motor symptoms and activities of daily living when compared to the placebo group at week 40. There is a possibility that this was due to a secondary placebo effect, but there is also a chance that there is a delay between treatment and clinical improvement. In saying this, I mean that GDNF may simply work to restore neural pathways slowly, not resulting in any functional change until that 40 to 80 week period. In the future, the researchers suggest longer exposure and/or increased concentrations of GDNF to attempt to achieve a more rapid and significant response. Though not an entirely successful first trial, there are lots of positives to take from the study aside from the reduction in symptoms. GDNF treatment resulted in a 100% increase in the brain area associated with Parkinson's disease and significantly increased dopamine uptake. 95% of patients that received GDNF for 80 weeks showed clinical improvement and the side effects were minimal. However, there is another breakthrough of this study that could have groundbreaking applications beyond GDNF treatment and even beyond Parkinson's disease. GDNF was administered via a skull-mounted port that bypasses the blood-brain barrier. As you can see in the figure, 4 tubes are inserted into the brain and the port is located behind the ear for convection-enhanced delivery. As Brae mentioned, dopamine cannot cross the blood-brain barrier, so with this new innovation, direct dopamine treatment may become a reality. This could apply to a wide number of drugs that are unable to cross that protective barrier, and it could open the floodgates of neurodegenerative disease research. There are also much more simple ways to relieve Parkinson's disease symptoms. Just by making lifestyle changes, patients can reduce their symptoms. It is well known that exercising increases dopamine production. By increasing the presence of dopamine receptors in the substantia nigra and the basal ganglia, and reducing the amount of dopamine transporters that take dopamine out of the synapse, exercise offers many neuroprotective benefits and can relieve Parkinson's disease symptoms. Another documented therapy that does not involve any actual medical treatment is musical therapy. Professionally trained therapists lead patients with Parkinson's disease through a variety of exercises, including song, dance, and practice with instruments, typically rhythmic instruments like drums. These patients show improvement in balance and movement, speech and communication, cognition and memory, mental and emotional health, and social connection. Studies have shown that music therapy can alleviate motor symptoms of Parkinson's patients, especially in terms of slowness of movement, or bradykinesia. Emotional status is also improved through music therapy. Practicing rhythm may help with concentration, focus, and movement coordination, whereas the emotional response to music could produce dopamine and influence the basal ganglia. This technique has been around for a while, but it seems to be gaining more traction again recently. In the figure on the right, you can see the more specific effects that music therapy can have on different parts of the body in a Parkinson's patient. However, newer areas of research have focused on adjusting the diet of patients with Parkinson's disease. It was recently found that both a low-fat, high-carbohydrate diet and a high-fat, low-carb ketogenic diet can both improve symptoms of Parkinson's disease, though the ketogenic diet resulted in a greater improvement in non-motor symptoms. The low-fat, high-carb diet can increase the amount of dopamine in the brain through 2 mechanisms, and we've seen several times that dopamine is a key element of Parkinson's disease. The first pathway is through tyrosine. Tyrosine is a dopamine precursor, and this diet allows it to pass into the cerebrospinal fluid more easily. The increased production of insulin resulting from this diet also leads to an increase in brain dopamine. Furthermore, the fermentation of fatty acids has been shown to improve gut motility in these Parkinson's patients, which is important as the gastrointestinal tract is often affected by neuron degradation in Parkinson's patients. As for the ketogenic diet, it mainly works through the mitochondria. This diet enhances oxidative phosphorylation in the brain, as well as neuron energy metabolism. This is significant because mitochondrial dysfunction is closely linked to Parkinson's disease, so increasing mitochondrial activity can counteract the progression of this disease. The researchers do leave us with a word of warning for now, though. This is not a Parkinson's disease cure, and they recommend that diet manipulation be done complementary to levodopa treatment. There is also a chance that the results of the study were due to weight loss or placebo effect, so these must be eliminated as potential explanations in the future. In this table, you can see the changes in symptoms, physical condition, and metabolic parameters of the patients. In both groups, all 4 parts of symptoms were improved, though the ketogenic diet seems to result in greater improvement, particularly in non-motor experiences. Both groups lost weight, and other than that, the most striking contrast is in the cholesterol levels of the 2 groups. This should be taken into account when deciding whether or not a patient is going to follow one of these diets, as we have seen that cholesterol levels often play a role in cardiovascular disease. You can see in this table the side effects experienced by the participants. While tremors were quite frequent in the ketogenic group, I think it is important to note that nearly all of the side effects seem to decrease over time in the ketogenic group, whereas the side effects in the low-fat, high-carbohydrate group increase in several cases. Based on the increased improvement of non-motor symptoms and this evidence of reduced side effects over time, it seems that the ketogenic diet is a realistic, effective option for Parkinson's patients to try.
If you were unable to get a good look at those tables, feel free to go back, pause, and take a closer look. Now, can you recall the 3 words you were asked to memorize earlier in the presentation? If you're able to, congratulations, but typically those suffering from Alzheimer's are unable to recall those words after only a few minutes. This test is used very early on in the process of diagnosing Alzheimer's, so if a person were to receive bad results, there would be further testing required to confirm their diagnosis. If you had trouble remembering the words, you can find them on the next slide.
Congratulations on making it through our presentation and completing the cognition testing activities. Hopefully you did well. Now, if I were to condense our presentation down into a few sentences, or take-home messages, I would say that the following are the major points you should know. Firstly, neurodegenerative diseases are caused by neuronal damage and are characterized by 2 main symptom groups, ataxia and dementia, or motor and cognitive impairment respectively. In terms of Alzheimer's disease, there is no specific cure, but this does not mean that it is untreatable. There are therapeutic options available, but they can only treat symptoms in order to improve the quality of life of the patient. Until an effective treatment is found, research must continue and preventative measures should be implemented in at-risk individuals. As for Parkinson's disease, it is important to note that the most effective treatments tend to focus on protecting and restoring dopaminergic neurons, as we have seen in stem cell therapy and GDNF treatment. Like Alzheimer's, there is no cure for Parkinson's disease, but recent breakthroughs, like the implementation of the skull-mounted port, indicate a promising future in the search for a cure. The next several slides list the references that we used in making this presentation. The asterisks indicate key references, or references that we found particularly useful. This could be articles that we drew a lot of information from, or sources that explain the treatment in question in a way that was easy to understand. These are also listed at the end of your worksheet and transcript. As for the figures used throughout the presentation, those that came from one of these sources were indicated by the number of the article or web page they were from. Those that were not from one of these references were accompanied by the link to their page. We hope you enjoyed the presentation and learned something new and interesting about neurodegenerative diseases. Thank you.